people with good reputations, that sort of thing.
It's time for the end of session quiz. I want you to pause the video, answer all the questions in the end of session quiz, and then restart the video, and then we'll go over the answers together.
All right, let's go through the answers to your end of session quiz. First question, what is the most common indication for a cesarean section? Well, this is prior cesarean delivery. Remember, don't be fooled into thinking that failure to progress is the most common indication. Failure to progress is the most common indication for a primary C-section, but the most common indication overall is a prior C-section. Next, what are some of the positive aspects of birthing centers? So with birthing centers, you're going to see lower rate of cesarean section, you're going to have lower infant mortality, you're going to have higher rates of breastfeeding, patient satisfaction is around 99%, but remember, there are no controlled trials that directly compare the safety of hospital-based deliveries with birthing centers. Also, the data can be somewhat confusing because birthing centers are usually only accommodating low-risk pregnancies. Next, what's the most important factor that leads to a successful forceps delivery? Well, this is an experienced operator. Remember, don't try this without extensive training. The risk for maternal lacerations and fetal lacerations is significant even for experienced operators. Next, in order to mechanically dilate the cervix, what two major options are available? Well, there's laminaria, which is made from seaweed and can be inserted into the cervix, and it'll absorb moisture and then expand and hopefully dilate the cervix in the process. Or you can use a Foley catheter, which you insert the deflated catheter into the cervix and then inflate the balloon. Next, a 25-year-old G1 P0 female is in active phase labor. She's dilated to 6 centimeters and 100% effaced. Her membrane spontaneously ruptured about an hour ago. She's not had any dilation for the last 2 to 3 hours. Continuous fetal heart monitoring has not shown any worrisome signs of fetal distress. How would you manage this patient? Well, there are several options for this patient. First, you can simply do nothing and just monitor the patient for an hour. There's a recent study that showed waiting 4 hours for cervical change is reasonable. Another option would be to place an intrauterine pressure catheter, IUPC, to measure the strength of the contractions. If her contractions are producing less than 200 Montevideo units, then she may need augmentation with oxytocin to give her a better chance of having vaginal delivery. If she has adequate contractions and still continues to have no cervical change, then she may be failing to progress and she may need a C-section. Next, what's the difference between an epidural and spinal anesthesia? Well, an epidural involves continuous infusion of local anesthetics or narcotics through a catheter into the epidural space. This can also be used for C-sections and procedures like tubal ligations as well. Spinal anesthesia is a single injection of anesthetic, and instead of going into the epidural space, it goes into the subarachnoid space. It has more rapid onset than an epidural, but it has a shorter duration. Next, a 35-year-old G3 P2 female presents to L&D already in the late active phase of labor. She reports that with her last baby, she had a very rapid labor and delivery. She's dilated to 9 centimeters and is fully effaced. She's complaining of pain and would like an epidural. What do you tell this patient, yes or no? Well, every situation is going to be different depending on the patient and the OB and the anesthesiologist. There's probably not an absolutely right answer to this question. However, more often than not, when a patient is multiparous and has a history of rapid labor and is already this far into labor, there won't be enough time to get an epidural. Systemic narcotics are also risky in this situation because they may cause some respiratory depression in the infant. So she's probably going to have an old-fashioned natural childbirth whether she wants it or not. Next, when considering labor induction, what's a good measure to predict if the induction will succeed or fail? Well, you can use the Bishop score. If the Bishop score is less than 5, then induction is more likely to fail. This is why ripening the cervix with prostaglandins or laminaria is a good idea to help improve that Bishop score before you consider other induction options like amniotomy and oxytocin. Next, what are the major complications of a forceps delivery? So you can have bruising on the face and the head, or you can have lacerations. Lacerations to the fetal head, the cervix, the vagina, and the perineum. Next, a 34-year-old G4 P3 female at 30 weeks gestational age wants to attempt a vaginal birth after C-section. She's had 3 previous C-sections. All of her previous C-sections were performed with low transverse incisions. Her last delivery was over 2 years ago. She denies any previous uterine infections at the time of her previous C-sections. How would you advise this patient? Well, this patient should not be offered a trial of labor after C-section. She's had 3 previous C-sections. ACOG guidelines say that some women can still attempt a VBAC after 2 C-sections, but not after 3. The rest of her history is good in regard to VBACs. She's had the right type of incisions. It's been over 18 months since her last C-section. She has no history of uterine infection. However, her number of previous C-sections should disqualify her for an attempt at VBAC because her risk of uterine rupture will be higher. So that's the end of this end of session quiz, and that's the end of this lecture. I hope you've learned something. Good luck studying.